The surgeon's fingers go into the wound before his instruments do. No light inside, no image, no way to see where the arrow stopped. Just the wet dark of someone else's body and a set of rules built from watching men die badly when those rules were ignored. This is how ancient surgeons pulled iron out of living flesh without x-rays, and what they understood about the human body to do it is stranger and more precise than it has any right to be. Start with what the wound actually is, because an arrow wound is not one injury. It is a cluster of variables that each change the answer. The shaft tells you the angle of entry. The head shape tells you whether the thing is moving cleanly through tissue or catching. The depth depends on draw weight, distance, and what the arrow passed through before it reached you. Whether it broke tells you if there are two problems now instead of one. Whether the head is barbed tells you that pulling backward means the hooks open into whatever they were touching, and your body itself has already started to close around it, muscle contracting, tissue swelling, the wound mouth tightening like a fist around the stem. So the surgeon standing over you in 200 BC or 1200 AD is not solving one question. He is solving 5 or 6 at once in the correct order with no instrument that sees through skin. This is where touch becomes the primary sense. Not guessing, not hoping. A trained hand pressed flat against the surface of the body around the wound can feel the resistance change as it moves towards where the head sits. A slight firmness against the surrounding. Give of healthy tissue a localized heat, a pressure that answers back differently than the tissue 2 fingers to the left. The surgeon probes the wound channel with a thin rod, feeling for resistance, for the particular stop that metal makes against metal when the probe's tip finds the head. He watches how blood flows. A dark, slow seep means venous tissue. A bright pulse means something else, something he does not want to widen toward. He watches the wounded man's face and hands, where the pain sharpens suddenly, where the body flinches against a controlled pressure that tells him depth and angle as clearly as any measurement. You are not a passive surface. You are a piece of diagnostic equipment, and your own reactions are data. The Roman physician Celsus, writing in the 1st century AD, was explicit about this. He laid out a hierarchy of inference. You observe the entry wound's shape. You assess what structure lies along the arrow's likely path. You consider whether the man can move the affected limb and how far, because motion tells you what is intact and what is not. Celsus was not inventing this. He was compiling centuries of accumulated Greek and Hellenistic practice. The same tradition that produced the Hippocratic texts, which had already noted that wounds behave according to pattern, that inflammation follows injury in predictable sequence, that the body gives legible signs to the observer willing to read them carefully and without rushing. Observation governed the first cut, not bravery, not speed. Observation. And this is why the obvious move was sometimes the wrong one. The arrow is in the body. Pull it out. Except the arrow entered at an angle, and pulling straight back means the head drags across a diagonal path through tissue it never touched, going in. Or the head is barbed, and pulling it backward causes the barbs to engage, hooking into the flesh the way they were designed to, turning extraction into a second wounding worse than the first. Celsus addressed this directly. Sometimes the wound had to be enlarged, a deliberate incision, extending the channel, straightening the path, giving the head a clean line of exit that did not exist naturally. This was not violence without purpose. It was controlled damage applied to prevent greater uncontrolled damage. The surgeon cutting into you to make a larger wound is not doing it carelessly. He is doing the geometry the arrow's entry path made necessary, and he is doing it because pulling without that preparation would tear through muscle and vessels that the arrow itself had avoided on the way in. Sometimes he did not pull at all. Not immediately. If the wound was deep, if the head sat near a vessel or a joint, if the tissue was too swollen to give the head a clean passage, he would pack the wound, reduce the inflammation, wait. Patience was not hesitation. It was the calculation that a better moment existed than this one, and that reaching into a swollen, angry wound was more likely to kill the patient than the wait. So the arrow is found. Located by touch, by blood behavior, by pain response, by the map geometry of where it entered and what lies between entry and rest. The surgeon knows what is in there and roughly where. The first logic test is passed, but knowing where the arrow sits is not the same as knowing how to get it out. And once barbed heads and broken shafts entered the problem, the extraction methods that followed were some of the most deliberate and quietly brutal procedures in the history of medicine. The barb is the problem, not the point, not the shaft. The barb, a smooth-headed arrow, pulled back along the channel it made, does what you expect. It comes out. Bloody, painful, but reversible. The path exists. The head, made it. Now it unmakes it in reverse. But a barbed head did not enter by spreading its hooks. It entered point first, the barbs folded back against the shaft by the resistance of skin and muscle, riding the compression of entry like a folded umbrella passing through a door. The moment it stops inside you and the compressive pressure releases, the barbs open, spring back out, set themselves into whatever tissue surrounds them, and now the geometry has changed completely. The channel that brought it in is no longer the channel that can bring it out. Pull backward, and you are not reversing the wound. You are making a new one from the inside. Celsus understood this and wrote about it in the 1st century AD without euphemism. When the head cannot be safely withdrawn the way it entered, push it through. Find the point beneath the skin, the slight resistance where the arrowhead presses against the inner wall of tissue, cut down onto it from the outside, and extract the head forward through the new opening. 2 wounds instead of 1, deliberately. The logic being that a clean second wound under the surgeon's control does less damage than dragging a barbed head backward, through a channel it was never designed to exit through. This was not cruelty dressed up as medicine. It was geometry. The shortest path out of the body was sometimes not the path in. Celsus also described a second instrument, a spoon-shaped probe that could be worked into the wound alongside the arrowhead, its curved surface sliding over the barbs and holding them folded against the shaft long enough to withdraw the whole assembly backward without the hooks catching. You are reading a 1st century solution to a mechanical problem that had been killing soldiers for 5,000 years before he wrote it down. He did not invent the solution. He recorded it because it worked often enough to be worth teaching. The refinements continued. By the 10th century AD, the Andalusian surgeon Albucasis, writing in his encyclopedic surgical text Al-Tasrif, had moved the instrument set further. He described purpose-built extraction tools, including arrow forceps, shaped specifically for gripping missile heads that had rotated or shifted inside the wound channel. Heads that had separated from the shaft, fragments of bone and metal sitting in configurations that no simple probe could address. Albucasis drew the instruments. Their shapes were not incidental. The angles of the gripping surfaces, the length of the handles relative to the working end, the degree of their curve, all of it was built around the specific mechanical problem of reaching into a human body along a narrow channel and removing something hard from something soft without destroying the path between them. Medieval surgeons were not imitating Roman ones badly. They were inheriting a tradition and extending it with new tools built for problems that earlier centuries had identified but not yet solved cleanly. Here is where the worst of it sits. The arrow that breaks, the shaft snapping under the force of impact or on a glancing blow, the head driving on without the stem, stopping somewhere deep with nothing above the skin to indicate its position except the entry wound and what the surgeon can feel. In these cases, the delay that the previous surgeon might have used as a virtue became a liability. Swelling closes the channel. The head migrates slightly as a surrounding muscle contracts and pulls. What was findable in the first hours becomes harder to find in the first days. Celsus noted this. Albucasis noted this. The window in which the wound cooperated with the surgeon was not infinite. There were cases in historical record where the extraction itself was survived only because the surgeon accepted something worse than the original wound. A full incision down to the head, a deliberate cutting open of the closed tissue, force applied to a body that had already begun trying to heal around the fragment because the fragment was not going to resolve on its own. The patient lived or did not, but the surgeon who reached that decision had not arrived at it blindly. He had watched enough men die of retained arrowheads going septic in the 3rd week to know that waiting was also a choice with a cost. Now, here is the part that changes the picture. Without a single x-ray, without any instrument that sees through skin, these surgeons had built a working map of hidden injury from observation alone. Weapon design told them what the head was likely doing inside the tissue. Entry angle told them where it traveled. Depth estimates, built from draw weight calculations and the known behavior of tissue at various densities, told them roughly where it stopped. Pain response under controlled pressure told them whether they were close. Outcomes across hundreds of cases told them which approaches killed patients and which ones did not, and the ones that did not became the approaches that Celsus wrote down and Albucasis refined and the medieval tradition preserved. They were not guessing. They were applying a model of the interior body built from the same method your ancestors used to read the dirt. Observation, pattern, prediction, test, correction. No single surgeon invented this. It accumulated across generations of men opening wounds and watching what happened next. The opening image still holds. You on the table, the arrow in you, the surgeon's hands moving over the surface of your body with a particular certainty. He cannot see inside you, but he has read 100 versions of this story in other bodies, and he knows which chapter comes next. Your skin, your muscle response, the heat around the entry point, the way your body flinches or does not when he applies pressure 2 inches to the left of the wound, all of it is still talking. He is still listening the way anyone listens to something that cannot speak directly. The needle without x-rays was never blind. It was reading you the whole time. And what it understood about the human body, built from nothing but attention and accumulated consequence, is what surgery still stands on.